Hi, in this lecture, we're going to close out the autonomic nervous system by learning about the neurotransmitters and the receptors. And this is more of the fun stuff, at least in my opinion. So when we look at the autonomic nervous system, we're looking at two main neurotransmitters. We have acetylcholine and we have norepinephrine. So these are the two that we've been looking at. We know that acetylcholine is released by all preganglionic axons. Remember, the preganglionic axons of the parasympathetic and the sympathetic all release acetylcholine at the ganglia. And remember, it's always excitatory because the pre is trying to stimulate the post, right, to relay the message. Acetylcholine is also used by all of the parasympathetic post-ganglionic axons. Now remember, when we look at the sympathetic nervous system, most of those post-ganglionic axons of sympathetic are going to release norepinephrine. And so what we have are things called cholinergic fibers and receptors and adrenergic fibers and receptors. A cholinergic fiber is the same thing as a cholinergic axon, or a receptor is one that's going to either release or bind acetylcholine, right? Choline, cholinergic. Adrenergic, think about norepinephrine, are the axons that release norepinephrine or the receptors that bind to norepinephrine. Now, the neurotransmitter effects vary. They can be either excitatory or inhibitory. It depends on the receptor. So we're going to be looking a little more detailed at some of these receptors that we see for the autonomic nervous system. So what you're seeing in this picture is you have your autonomic, and then you have your somatic over here. Now we have our pre-ganglionic here, and then we have our post. So notice when we're looking at our pre-ganglionic, the neurotransmitter is always acetylcholine, like we said, right? Whether we're sympathetic or parasympathetic, acetylcholine is always released, and it's excitatory, and this will be a cholinergic receptor. Now we'll talk about these names in a minute. You see nicotinic and muscarinic. The receptors are actually named for the drugs that bound to them when they discovered them. If we look at our post now, remember if we're looking at our post, they're mainly releasing norepinephrine. The adrenal medulla is special. When the sympathetic, the preganglionic go to the adrenal medulla, that always stimulates the release of epinephrine. So this adrenergic receptor can bind norepinephrine, but they also combine epinephrine, norepi and epi. So the receptors for acetylcholine are two types. They're called nicotinic and muscarinic. And the way they discovered them was that nicotine binds to a nicotinic receptor. So when you ingest nicotine in your body, it binds to a nicotinic receptor, and your body doesn't know that it's nicotine and not acetylcholine. So similar. Muscarine is one that comes from, you might have heard of these mushrooms. So the nicotinic receptors are excitatory. When acetylcholine binds to a nicotinic receptor, it's going to have very excitatory action, same as nicotine, right? So in our somatic nervous system, remember we look at somatic when we're looking at muscle. Those are all nicotinic receptors because we know that when acetylcholine binds for skeletal muscle, it is excitatory, right? It was going to depolarize and allow that nerve impulse to come down and go down the T-tubules. So we know that in the somatic division, they're always excitatory. And it's critical for muscle contraction. And this is a picture. You probably remember seeing something like this when we went over skeletal muscle. Acetylcholine was released at the synapse, bound to receptors, nicotinic receptors. That's what opened the sodium channel and allowed that to depolarize. Now let's look at the autonomic nervous system. If we're looking at the autonomic nervous system, these nicotinic, these excitatory receptors are at all the ganglia. So we said that acetylcholine was released by the preganglionic axons of both the sympathetic and the parasympathetic, and it's always excitatory. So it makes sense, right? It's going to be excitatory because you're not going to send an impulse out to the ganglia and be like, forget about it, right? You want it to keep going. You're trying to send some information. So nicotine also binds to those receptors and causes excitatory information. In fact, nicotine is going to excite both your parasympathetic ganglia and your sympathetic, right? Because your body doesn't know the difference between acetylcholine or nicotine binding at all these receptors. So you get both of these with nicotine, and especially nicotine poisoning. But if you take in nicotine, your heart rate goes up, your blood pressure goes up. Too much nicotine can cause sweating, vomiting, diarrhea, and excessive salivation. So those are all effects of that. Now, the muscarinic ones, they actually bound to something called muscarine. They can be either excitatory or inhibitory. Now, in your digestive system, they're excitatory. So when acetylcholine binds to the muscarinic receptor in your digestive system, it increases digestion, right? D activities, secretion, motility, helps you digest your food. In the heart, when acetylcholine binds to the muscarinic receptors in the heart, it opens potassium channels. And you might remember, if you open potassium channels, potassium always leaves. And when that leaves, that's going to drop that resting membrane potential. It's going to hyperpolarize it, and it's going to slow it down. It's going to be inhibitory or slow heart rate down. So when acetylcholine binds in the heart, it's inhibitory because it binds to a muscarinic receptor. When acetylcholine binds to skeletal muscle, it's excitatory because it's a nicotinic receptor. So it's the receptor that's going to determine the effect, not the neurotransmitter. Now, there's a whole bunch of medications that are more of an anticholinergic effect. So these are, you're not memorizing this list. I just want you to know that anticholinergic medications, the mechanism is to block acetylcholine. So they basically are antagonists to it. They are anticholinergic, right? So they're going to prevent it from binding. So they can have a lot of side effects that you would see if you had issues with it. Like, for example, your heart rate would go up because you don't have it slowing it down. We know we would have issues in our digestive system, right? Because we don't have it, exciting, right? Helping with digestion. So these are some of the common side effects that can happen with a variety of these medications. I just wanted you to be aware of it. Adrenergic receptors. Now, adrenergic are going to bind norepinephrine. They also bind epinephrine because epinephrine will come from the adrenal medulla. It's technically a hormone there, but it's going to have the same effects. When we look at adrenergic, we have two main categories. We have alpha and beta. And we're going to learn an alpha one type of alpha. There's more than one, just one. And we'll learn 3 types of beta. So your alpha 1, Greek letter alpha, are excitatory. When norepinephrine binds to an alpha 1, it opens calcium channels, and calcium rushes in because you have more calcium outside of the cell. If calcium comes into muscle, it causes muscle contraction. So these tend to be found in smooth muscle. And the main areas of smooth muscle are in your blood vessels. So your blood vessels have this opening. It's called the lumen. And when norepinephrine binds to an alpha 1 receptor, it's going to make that lumen shrink. So that's called vasoconstriction. And when it vasoconstricts, the pressure in there goes up. So it's how we raise blood pressure. It also closes sphincters in our GI tract. We have smooth muscle, circular smooth muscles, and think of them like doorways between organs. So it kind of like closes down the sphincter so the food can't be processed and move through. Now, beta, we're going to do 3. Beta 1s are excitatory. We mainly find these in cardiac muscle. There are some also in skeletal muscle. So alpha 1, smooth muscle, beta 1, skeletal and cardiac. And we look at this a lot in AMP2 when we look at the heart, because when norepinephrine binds to a beta 1, and remember, same, if epinephrine binds to it, this opens sodium and calcium channels. So now sodium and calcium rush into cardiac muscle, and it's going to make it contract faster. It's going to raise the heart rate, and contractility is the force of contraction. So it's going to contract harder, stronger contraction, so it pumps more blood out. This is also what increases skeletal muscle metabolism and contraction. Now, beta 2, notice, are inhibitory. So when norepinephrine or epi bind to these, it relaxes smooth muscle. So again, remember, it depends on the receptor. So if you look at smooth muscle, particularly in the respiratory tract, so we're looking at the bronchi and the bronchioles, they're the smooth muscle tubes in your lungs. Now what they're going to do is open up, right? They're going to open up or dilate, which will help increase airflow in your lungs. It can help relax some smooth muscle in your blood vessels to vasodilate and open them up, particularly, mainly the ones to your skeletal muscle. Because when your fight or flight is activated, you need more blood to go to your skeletal muscle so you can fight or flee. And this is how we can increase blood flow there. Now, beta 2 is going to decrease secretions in your GI tract. So we're basically, when we're looking at our alpha 1, we're constricting, right? We're not moving the materials through. And we're also, with our beta, norepinephrine binding to those is going to slow down digestion even more with secretions. And then the beta 3, I'm just mentioning, they're in your fat cells, adipocytes. And when norepinephrine or epi bind to these, it's going to cause lipolysis. And lipolysis is breaking down fat for energy. So you've seen this already. It was in a previous lecture, but I do like how you can see the sympathetic nervous system with the chain ganglia, right, that run on either side of the cord. Your collateral ganglia are here. Here's the adrenal medulla. So we know all those pre-ganglionic axons are going to synapse in the ganglia, and then they're going to go out to the effectors. And when they get to the effector, we're mainly looking at norepinephrine, and norepinephrine binds to an adrenergic receptor. So you can see the different receptors we talked about, and just focus on the ones from this lecture and their effects in the body. And that's basically how it works. So drugs, medications, this is a primary factor for how a lot of medications work. We have agonists and antagonists. An agonist is going to augment or enhance that particular branch of the nervous system. So a parasympathetic agonist is going to increase the effects of acetylcholine, right? It's going to basically mimic acetylcholine or increase it. So there's something called pilocarpine, and pilocarpine, or you can say pilocarpine, is a drug. It blocks acetylcholine. Got ahead of myself on that one. It doesn't block it. It increases the effects of acetylcholine. I'm going to try that again. So when you release it, it's basically like enhancing the effects of acetylcholine. So it would slow down your heart rate. It is used often for glaucoma. They have eye drops with this in it. What I understand about it is it makes the pupil constrict more. And if the pupil constricts more, it's going to help with the movement of the fluid behind the eye and sort of help with the drainage of it. There's acetylcholinease inhibitors. So if you're blocking acetylcholinease, right? Remember, this is what breaks down acetylcholine. Then you could increase acetylcholine at a synapse. There are sympathetic agonists. So again, these are things that are going to enhance norepinephrine and epinephrine, or they basically mimic them. So they're called sympathomimetic drugs. Don't worry, you don't have to say that. But these are agonists. So we already talked about the tricyclic antidepressants. One of the things, remember, they affected norepinephrine, dopamine, and serotonin. Well, they block, right, and keep norepinephrine in the synapse longer. So that's considered an agonist. But albuterol is a new one we're talking about, and albuterol binds to the beta 2 receptor. So that drug binds to the beta 2 and mimics norepi and epi. And remember, when we talked about the beta 2 receptors, that when norepinephrine binds, it's going to relax your smooth muscle and your bronchioles. So it's going to dilate the bronchioles and help move air. So a lot of times people who have asthma will have albuterol, and it's inhaled into the lungs. There's antagonists. We kind of talked about some anticholinergic drugs, but basically an antagonist blocks it. So a parasympathetic antagonist blocks the effects of acetylcholine, and atropine is one that is an antagonist, right? And so when you give atropine on the heart, it's going to block the effects of acetylcholine. It basically prevents it from slowing the heart down, so then it would increase your heart rate. There's sympathetic antagonists that block norepi and epi. So a beta blocker, right? Its name tells you it's going to block the effects of norepi and epinephrine. So these normally block the beta 1 receptor. They're like a little barricade that plug it up so that the norepi can't bind, or the epi. So these slow your heart rate down and prevent arrhythmias. There's alpha 1 blockers. These block the alpha 1 receptors. Remember, we said that if norepinephrine binds to an alpha 1, it's going to cause contraction of smooth muscle. So we would be looking at vasoconstriction of blood pressure, vasoconstriction of blood vessels, which would raise your blood pressure. Well, we block the receptor, now the muscle relaxes. So now your blood vessels open up, they vasodilate. This can be used in your ureters and urethra for your urinary system. Maybe there's a kidney stone, so it can help relax and open those muscles up. So we know that both epi and norepi bind to the adrenergic receptors, and typically norepinephrine tends to work a little bit better on these alpha-1 receptors. And even though epi can also bind, the norepi seems to work a little stronger, whereas epi tends to work a little better at your beta receptors, but they bind both of them. So you have this chart in your book just kind of doing an overview of some of the medications. You don't have to memorize all the names, but you should have an idea of what it would do if I tell you that it's a sympathetic agonist or a sympathetic antagonist. We have talked about nicotine, okay? We talked about the pilocarpine. We talked about albuterol. Now, the last thing, I just want to finish up with two quick things, is autonomic reflexes. We've already done reflexes. It's very similar. You have a reflex arc. The difference for your autonomic is it's coming from maybe your stomach or your urinary bladder or your large intestine. So it's coming from an organ, usually a visceral organ. Information still comes in and you still have information going back out. So we still have our sensory information coming in. And in this case, it's our autonomic nervous system. Notice we still involve the central nervous system, but our output, our motor, is going to involve the ganglia that we talked about, right? It won't go directly to the effector. So there's some reflexes that it's important to understand some of these. Some of our parasympathetic reflexes is our parasympathetic really controls our defecation and urination. So these are reflexes that are caused by when your bladder gets full. It's a stretch reflex, so information goes to your brain, you're where you have to go, so you can relax the sphincters and you can go. So these are two examples of some parasympathetic reflexes. There's also sympathetic reflexes that we're going to look at. And we talk more about these when we get into ANP2 because it's involving, some of the systems we do then. But a couple reflexes for the sympathetic nervous system is there's a vasomotor and cardiac reflex. The pupil reflex we actually already did in lab when we did the light in the eyes and we saw the change there. But when we're looking at sympathetic, a lot of them control our heart rate and our blood pressure. So your vasomotor is if there's a change in blood pressure, the reflex corrects it, restores basically homeostasis. And so these use a lot of your chemoreceptors and baroreceptors. So remember that the baroreceptors and the chemoreceptors are going to be important for blood pressure changes. So baroreceptor reflexes are monitoring stretch. And they monitor stretch in your large arteries of your body, like in your aortic arch and your common carotid artery that goes up your neck. And so what they do is if the stretch goes up, that means that your blood pressure's gone up, right? Blood's hitting the wall, it's stretching the blood vessel. That activates the baroreceptor and it sends information up to your cardiac centers and your medulla oblongata. And so you can change your heart rate to bring your blood pressure back down. So if its blood pressure goes up and it's stretching, then the information goes up. You have a cardiac reflex and it's going to bring your heart rate down to bring your blood pressure down. Or if your blood pressure is falling, there's less stretch, the information goes up to your medulla and it raises your heart rate. So the baroreceptors are really important at monitoring blood pressure, and we have these reflexes that try to fix it by changing our heart rate. We have chemoreceptors that look at things like if your oxygen level in your blood falls, or if your CO2 levels go up, or if you have too many hydrogen ions, if your pH changes. And chemoreceptors also send information up for reflexes to help control your respiratory rate. If your oxygen falls, your respiratory rate will go up, so you can try to get more oxygen in. And we talk a lot more about these later in ANP2. But I do want to mention tone. So when we did skeletal muscle, we talked about muscle tone, right? It's how fit you look. If you have more muscle tone, you see your muscle definition because they're always partially contracted. There's two examples of tone I want you to know for the autonomic nervous system. There's sympathetic, which is the tone on our blood vessels. So our blood vessels are always partially constricted. They always have norepinephrine on the alpha 1, keeping them constricted. And I want you to think about this as like a dimmer switch. So it's always contracted. But what happens is you can back off a norepinephrine and the blood vessels open up, or you can constrict harder and they constrict even more. So we can increase or decrease the amount of norepinephrine to make the blood vessels constrict more and raise our blood pressure, or make them open up and lower our blood pressure. And that's what those alpha blocker drugs do. They interfere with those nerves, those sympathetic fibers, to help constrict, or in this case for blood pressure, you would want to relax, right? If you had high blood pressure, you would want to open it up or dilate. So that's your sympathetic tone. Your parasympathetic tone is usually just called vagal tone because most of it's carried by the vagus nerve anyway. And one of the most important things on this is your heart rate. So your heart, if I were to cut the vagus nerve to your heart rate would go up to maybe 90 beats per minute. But your heart rate is not 90. Because the vagus nerve is always innervating your heart. It's always releasing acetylcholine all the time to keep your heart rate slower. And that's called our vagal tone. And when you exercise and do a lot of aerobic exercise, you increase the vagal tone, so you have a lower resting heart rate than someone who does not exercise. And we have a normal tone, vagal tone, in our digestive and urinary systems for like baseline function. So during stress, the sympathetic overrides this, right? Like your heart rate goes up. However, just normally we have this vagal tone that keeps it nice and low. So that finishes our material on the autonomic nervous system.